good afternoon. My name is Aaron Kroll, and I'm the Vice President of Business Development here at MTM. And let me be the first to welcome you to our Communities Without Barriers webinar, focusing on the unique needs and opportunities for improved care, especially to the aged, ill, and disabled. I'd now like to introduce you to Alaina Macia, the President and CEO of MTM. Alaina is a 10-year veteran of MTM and has personally led more than a dozen statewide and regional programs, including medical transportation and other services. She also spearheads MTM's expansion into new products and services, with many now focused on home and community-based services and long-term care needs. Alaina is also an active leader with many associations and boards, such as the National Council of Washington University's Institute for Public Health. Please join me in welcoming Alaina Macia. Alaina?
Thank you, Aaron. Thank you, everyone, for participating today in our webinar. I know you're all very busy as we're all responding to new RFPs for Medicaid managed care expansions, dual-eligible demonstrations, and also long-term care programs. But that's really what we're here to talk to you today about, are some of the tools and skills that MTM would like to provide to you today so that you can build these into your models as you move forward. As we're all aware, healthcare reform is in place, and the goal of healthcare reform is to provide healthcare to millions of Americans that have never had it. And to pay for this new expansion, they're really looking at two ways to contain costs and divert savings into these new programs. And the number one way is by managing dual eligibles, Medicaid and Medicare individuals that are really driving most of the expense in the healthcare model at this time. As we're all mostly aware, 90% of an individual's healthcare cost happens in the last year of an individual's lives. And so CMS is targeting this membership group, putting them into demonstration programs to save numerous dollars and redirect those dollars to millions of Americans for health care coverage. We're here today to talk about a large portion of that care, which is home and community-based services. The goal of home and community-based services is to help people stay in their homes for a long time and avoid long-term care institutionalized settings. And the savings is great. Just in the healthcare, setting aside the healthcare costs, focusing just on the daily living costs. The long-term care programs and long-term care facilities today cost about $36,000 a year, or about $100 a day for a bed, versus $9,000 a year for somebody to stay in their home. But providing services to people in their homes is something that managed care organizations have not done as of late, and it's going to really require new skills and new tools. And if it's not provided well, it can create a lot of frustration for your members and also your case managers. But home and community-based services provided in a high-quality, streamlined, efficient manner can add a lot of value to your program. It can really improve member satisfaction, lower healthcare costs, and also improve healthcare outcomes, which are all the things that you're being rated on through 5-star ratings and HCBS measures. You know, these are the important things that you want to keep in mind as you're building your program. We really want you to leave today with those two key points. If you provide home and community-based services well, it can add a lot of brand value to you, lower your costs, improve member satisfaction. Not providing it well can really cause a lot of complaints and frustration from both your members and your case managers. When I think about home and community-based services, I think about how they're really being provided to simulate the village-like lifestyle that was in place over 100 years ago. If you think back, prior to the invention of the automobile, people lived within a mile of their home, and they could access the grocery store or the market or church or a medical provider by just walking. You know, we've had a lot of advances in the last 100 years, from food production, higher yields, to higher standards of living, and the invention of the automobile, as many, many more inventions as well. But those three things have led to, unfortunately, obesity, sedentary lifestyle, and in the case of the automobile, urban sprawl, which as somebody ages results in them being confined to their own home, isolated from their communities. As we we look to get back to the basics on a lot of these problems as it relates to food production. We all want to source our food more locally and in a higher quality manner, as opposed to the sedentary situation. We're getting more active. Our communities are being redesigned so that they're livable, walkable communities. But until then, to address the urban sprawl issue and people being isolated in their homes, insert the home and community-based service model. The home and community-based service model is, the goal is to provide all the services that an individual needs to remain happy and healthy in their home. And when it's coordinated in a high-quality manner, it can result, like we said, in a more satisfied member base who will talk positively about your health plan and extend your brand into the neighborhood. We also are going to talk about what we think MTM's model for our clients is. Our clients are looking to MTM to provide services to them as they grow. We're all in a high-growth atmosphere right now, and our health plans are looking to MTM for solutions. And in this way, in home and community-based services, they're asking for our best practices and how we would provide home and community-based services for their members. And we're going to talk to you today about a care coordination model that can help facilitate home and community-based services so that your members can stay happy and healthy in your home. And if your plan is talking about providing these services, you can just adopt our model and use our points as you consider how to roll these programs out. A little bit about MTM. A lot of you already know who MTM is, probably already working with us, but for those of you that aren't, MTM is a national transportation management firm. We've been in business since 1995, providing services to Medicaid and Medicare members throughout the country. When our founders decided they were going to tackle the problem of transportation for individuals trying to access healthcare services, they realized that there were plenty of transportation providers in the communities they wanted to serve, but yet they were fragmented, not held to high quality standards, and they didn't know how to serve the medical community. They developed a model like their managed care background. Both the founders had experience in managed care organizations, and they designed a program like managed care, a network of transportation providers, a customer service center for the access point, a claims adjudication department to pay providers and make sure services were provided prior to payment, a quality department to oversee complaints and issues, but also the whole providers to a very high level of quality. And lastly, the secret sauce, our care management department, the department that focuses on the medical facilities and the individuals that require reoccurring appointments and higher touch services. Over the 18 years that we've been in business, we've become even more involved in helping our health plans improve healthcare outcomes, designing programs to increase HCBS measures, and always being a partner to our health plans. We've also sought quality accreditations on behalf of our clients, such as URAC. And just a brief note, we are a Missouri certified WBE, and we have an affiliate organization certified in Indiana and Illinois, and we're always, pursuing those certifications in new areas. Just to cover our national footprint, MTM is in 28 states, providing over 7 million trips a year and serving 3.5 million members. We have 5 customer service centers: St. Paul, Minnesota, St. Louis, Missouri, Houston, Texas, Washington, D.C., and Western Virginia. And we're in the process of opening 2 new call centers, one in Madison, Wisconsin, and another in New York City. And through this service area, we're serving special needs populations, Medicare Advantage, dual eligibles, and helping on long-term care expansions as well. We're evolving as our clients are evolving. As healthcare changes, we want to be a good partner, and we're evolving to meet our clients' needs. We really see transportation as an integral part of member care plans, making sure they get to their preventative and life-sustaining healthcare appointments. And this is just one component, as we'll talk later, that makes up the home and community-based service model. But just to highlight a few other areas in case you have any needs in these areas, you can follow up with with MTM, we're providing prior authorization on non-emergency ambulance services and post-claim review on emergency ambulance runs, saving money for our clients. We're also providing call center service to many of our plans that need support, additional support through their member services departments on education and outreach, 24/7 services, and weekend services as well. And lastly, what we're here to talk about today, our home and community-based service model. Home and community-based services are in place to serve your members, to keep them in their homes, but keep them happy and healthy. And we all know what they are, but I'll just run through them real quick. Meals, home care, home modifications, which can include building ramps, widening doors, changing tubs into showers, home cleaning, transportation, companionship, and last, but maybe most important, community-based social life. We talked previously about long-term care institution settings, and also there's independent living centers. Those facilities, while they're more expensive, provide a valuable additional benefit that living in your home doesn't provide, and that's a community-based lifestyle. In those facilities, you can access a recreation room or a central room so that you can play cards with other individuals, eat together, and have somewhat of a social life. When you're in your home, you become isolated from the community, which can lead to depression and ultimately reduce your healthcare outcomes. And so we think an important part of home and community-based services is reestablishing individuals into the community activities that they used to be participating in, whether that's church, bingo, a Kiwanis Club, going to the VFW hall. We want to make sure your members are reconnected with their friends and the community that they love. And we think that that's something that you should definitely keep in your model as you move forward. It's key to use a quality service network of providers to provide home and community-based services. These services are provided in somebody's home, and they can really, either make your brand look good or make it look really bad if services aren't provided through a quality service provider. So simply having a network is not the goal. You want to have a quality network of local home and community-based service providers that understand how to work with the community that you're serving and understand, working with frail and elderly individuals. MTM's model for providing a quality service provider network is to hire network development staff that are skilled in the areas that they're contracting and monitoring. So, for instance, the individual that would develop the home modification portion of the home and community-based service network would have a background in contracting for services, being a contractor, providing home modifications. They would know how much it costs to build a ramp or retrofit a tub into a shower, know what the quality product should look like, and also have the ability to audit and train the home and community service providers to make sure that they're providing the level of a quality product that you're intending for your member. They also would ensure that they have all the credentialing required for that service area. So what licenses and insurance and background checks and training are required to provide quality services in this area. They'll also make sure that those service providers and their staff are trained on how to work with frail and elderly individuals. That's a real skill. And if I think about my grandmother, who wouldn't let somebody into their home and screened, who came into her home very tightly, it's a key component is just gaining access to an elderly person's home. For instance, my grandma wouldn't let anybody in the front door because she knew she didn't know them, because everybody she knew came through the side door. So little things like calling people in advance, reconfirming with them that you're coming out, how you're going to identify yourself when you come on site, that you'll be in a uniform, that you have a badge, my name is, and then gaining access to that home is critical. And we'll talk about some ways MTM's care coordinator can make sure that those appointments are kept later on in the presentation. And then lastly, our network development staff will be auditing those providers providers in the field and the services they've provided to make sure that they're representing the quality that your brand is expecting from your network. And lastly, satisfaction surveys, not just of the member, but any caregiver or neighbor, whoever's the vested party in the member's life, to make sure that we're getting the real story. A lot of elderly people might not tell the truth about a relationship that they have with a service provider because maybe they built a relationship with them and they don't want to tell them that they didn't come today, or they're afraid that they might retaliate if they complain. So we're going to make sure that we ask caregivers and other stakeholders about the level of satisfaction that the service providers are providing. Really, what we see as the most integral piece in this whole home and community-based service, other than a quality network, is having an individual who's managing all the home and community-based services for your members, and that in MTM's language is our care coordinator. They're really an extension of your case manager. They're not replacing your case manager. You want your case manager focused on managing the clinical care of your members, and that's really what they want to focus on, and that's what they're skilled at, and that's what they're being compensated to provide. But at the same time, these home and community-based services are key to providing quality health care outcomes and lowering the overall costs of your member. So in our mind, the case manager and the care coordinator are closely linked, ensuring that the member's needs are being served. But the case manager is handing off the plan of care as it relates to home and community-based services to the care coordinator. And then the care coordinator is contracting. Well, the contracting has already been set up, but they're initiating all the prior authorizations for transportation, meals, home care, any home modifications, and also adding in that component on the social activities. This is really a key part of the solution. Home and community-based services are probably only 10 to 20% of the overall spend of your member, but not done right can create 80% of the frustration of both your member and your case manager. And so the goal here is that you set up a network proactively to meet the needs of your members, and then the care coordinator is executing on the plan of care to get all the services provided in a streamlined, efficient manner. Again, your care coordinator leaves your case manager free to focus on clinical care. They're not duplicating what your case manager does. They're augmenting it and helping them be more efficient so they can focus on managing their caseload. That's really what they want to do. We don't want a room full of angry case managers because they're on the phone for 2 hours trying to arrange for a ramp to be installed at their member's home. So the care coordinator is key in simulating the village-type approach. So that's the real crux of the issue here, is that we want the member to feel taken care of and that they're a part of a community and that the care coordinator is there as a resource to them. And so that way we can get any proactive issues addressed, proactively through the care coordinator. They're making sure that the service providers are coming on time, providing quality services. They're reminding members and caregivers about appointments, and they're arranging things so that the member is satisfied. So for instance, if a renovation company is coming over to install a ramp or changing that tub into the shower, they might try to schedule it when the home care attendant is there so that the member feels safe letting somebody into their home, because that renovation company is only going to be there probably 1 or 2 days, and the member isn't going to trust somebody to be in their home. But when the home care attendant's there, they'll feel more comfortable about allowing them access to their home. Ultimately, they're acting as a liaison between all involved parties: the case manager, all the home and community-based service providers, the caregiver, and the member, and they're scheduling and coordinating everything seamlessly. And again, adding in those social activities, making sure the member is getting out of the home, or that they're coordinating people to come to the home so that they can have that social life. Just wanted to give you an overview of how we think the process should work. Whether you have your own case managers or nurses doing that really critical in-home assessment, or if you're outsourcing it to a company like MTM as part of the whole entire home and community-based services model, the process really starts there. That never contracted for these services before, and you need to establish rates and levels of service with each one of these service providers, and you need to have those rates in your contracts and then in your software, because as we all know, the other way that healthcare reform is going to be paid for is through audits and fraud and waste and abuse reduction. And we've been seeing that OIGs are not just, here, let me get rid of that real quick. Excuse me. We've been seeing that OIGs are also not just auditing that services have actually been provided, but also auditing to see if how you've paid your providers actually matches the terms and conditions of your contract. And I think that's something that is new to all of us. We're all at risk under capitation arrangements, and so we're not used to those type of situations. So if you don't have good vendor management software tracking services and rates and making sure it's matching to your contract, you could really be exposing yourself and creating a lot of pain down the road. If you outsource to a home and community-based service provider, you want to make sure you're working with a company that has experience managing eligibility and encounter data processing, in the HIPAA compliant formats. And we just think that's critical, that we're all being rated on our encounter claim submission and how clean those claims are, and so definitely makes us a huge priority. The last two pieces I think are really key to home and community-based services. It's the portion that gives you real-time information back to your case manager. The first is web-based vendor portals, and beyond just the real-time communication, you're building a network of providers in large regions, sometimes with providers who might not provide a large amount of services for you because maybe they're home modification providers and they're only working with you once or twice a month. Well, it's key that you have software that allows them to work with you seamlessly. They're not going to be skilled at CMS regulations and what all the information they need to provide for claims. You need to provide a web-based platform that allows them to receive prior authorizations easily and be able to provide the supplemental information back to you seamlessly that services have been provided. The second piece on the real-time connectivity and vendor management piece is smartphone applications. We think a key component of home and community-based service providers is the fact that they're providing daily services to your member and can be an early warning sign if there's something changing in that member's state, so that we can get proactively involved with their health care and avoid potential rehospitalizations. And the way that can happen is simple applications on their phone that says they're en route to services, they've provided services, services are complete, and then any information to show that services are complete, maybe a picture of a ramp that's been installed. And then also have a field where they can enter any information, like I noticed that there is a really dense carpet in the member's bedroom. It's a potential hazard, trip hazard. Should we take a second look at that and, address that problem? Or I'm Joe's transportation service, and I transport this member every day, and today they seem to have a very degraded state as compared to yesterday, and maybe somebody needs to follow up with your member. And that could trigger an appointment with the primary care physician and to make sure that the individual taking their medication, eating their meals, and again, get involved before potential rehospitalization with the ultimate goal of improving healthcare outcomes and reducing your members' costs. Excuse me, a little bit of summer cold. But we wanted to give you an example of an actual potential case study. Margaret Smith, she's an actual member that we could all be serving. She's a 78-year-old female. She has chronic kidney disease and diabetes. She's a dual eligible beneficiary, and she just recently fell on that disc carpet in her bedroom, and she broke her hip, was hospitalized, and then she went to a rehabilitation facility, and she's been there for a couple months, and she's being discharged home finally. And her husband's there, but he's 86 years old, and he's the primary medication that requires an RN to administer. She's not comfortable administering it herself. She needs a home health aide for bathing and light housekeeping because she's still recuperating. And she needs meal service for the next 60 days because she was the primary meal prepared in her home. And she also needs transportation to her follow-up medical appointments, and she's really involved in her church and also her quilting club, and she's really anxious to get back and see her friends. So she needs some transportation to those social activities as well. So the plan of care is provided to the care coordinator. She's augmented that plan of care with the social activities and the transportation appointments that she needs. But she's really focusing on making sure that all the home and community-based services have been authorized and that they're occurring in those critical first few days at home. We want to really make sure that there's no rehospitalization. So we want to make sure that her appointments have been scheduled, that she's getting there, that she's receiving the meals, that her and her husband like the meals, that she's taking her medication and having no adverse reactions to the medication. The care coordinator is talking daily with the home and community-based service providers, maintaining oversight and management of them, making sure they're getting there on time. She's also providing real-time communications back to the case manager, letting her know that services have been provided, and also letting her know if there's any additional things that should have been contained in the plan of care that were missed. For instance, they put the ramp in, they changed the tub to a shower, but nobody changed that carpet out that she tripped on in the first place. And so we need to go back, authorize that modification, and make sure it happens. And then she's reporting outcomes and milestones back to the case manager and the frequency that case manager wants, either daily, weekly, or monthly. And that's how MTM envisions the model working. Obviously, you can tweak that model to your needs. And but the real goal of this whole care coordination model and the home and community-based service model is to improve the continuity of care for the member and make them feel like, somebody's really taking care of them, looking out for them. That's going to allow the daughter to feel really confident about the care her member is receiving, and she might then, as a result, refer your plan to her friend who has a mother that needs home and community-based services. So providing home and community-based services in a way that reduces fragmentation and improves services can be a real brand augmentation marketing tool for you. And there's no better marketing than word of mouth and personal stories. So I think it's something that you should really focus on providing in a high-quality manner. And also, it's a significant cost avoidance tool. So we all know that we have to avoid rehospitalizations and those significant costly episodes. But ultimately, the real goal is improved healthcare outcomes so that you can have high 5-star ratings and get your bonus payments. But we all know that that's not the only goal. We all know that care coordination, improves results, but there's actually been studies out there that prove that they have improved outcomes as a result. In this case, from the University of Colorado Health Sciences Center, they saw a 26% decline in hospitalizations and a 7% improvement in healthcare outcomes. And that's significant because we're talking about a frail and elderly population, and those are significant results. We would love to hear from you and answer any of your questions as a result of this presentation, and so please feel free to contact us. We want you to learn more about MTM and how we can potentially help you with your home and community-based service delivery model. And we're available to do a free assessment of your needs or to talk to you about any gap that you have in your home and community-based service network. We're not a one-stop shop, and we're very flexible, and so if you would just need support in a few areas, we would love to talk to you about those needs. Thank you very much for your time and attention. I know